Hey guys, so we've just done a 2-day training course in London on spinal manipulation and we covered loads of stuff. It was a great fun 2 days. But as with all of our courses, the main emphasis for us is about education and giving people clinical understanding as to what the techniques are and how you are actually going to incorporate them into your treatment process. I'm not a fan of just students coming on, learning techniques and then leaving without any real clinical thought processes as to how it fits into the treatment process. And so these are some of the questions that we discussed as a group. So number one, we looked at risk versus reward. Now this is my favorite. What is the risk of the technique versus the reward of the temporary neurophysiological outcome? What that means is that you can see some heavily aggressive, massive long-levered manipulations on social media, smashing these patients to pieces to create what is in reality a temporary neurophysiological outcome of symptomatic and functional modification. Is the technique and the risk of other issues going on wrong with it worth that temporary reward? And I would probably say the majority of the time, no, it's not. We can do these techniques in a much more gentler way. We can elicit the same responses with less aggressive manipulation. So it's always valuable when we look at these things to consider the risk versus the reward of the technique and what the other options are with it. We also looked at case history. That is one of the most important parts of the whole process. You have to do a thorough case history before you start clicking anybody. 80% of your diagnosis is made through case history, and it's really important that you do that because the case history keeps you safe. Manipulation, guys, it's not about how to do a technique, it's knowing when not to do a technique. That's the most important part of the process. If you're not doing case history, speaking to the patient, the mechanism of action, having a clear understanding of what you're doing, why you're doing it, that's when problems occur. So case history, case history, case history. We also looked at the individualization of treatment. So the thought process of you can't just do the same thing for everyone. You see these people on social media all the time. You know, patient comes in with an ankle problem, they get crack from the head to the foot. Wrist problem, crack from the head to the foot. Back problem, crack from the head to the foot. That is not treatment. Yeah, that is just smashing patients with no clinical thought process. You have to be asking yourself, why this patient? Why this problem? Why now? Individualization of the treatment process, using the appropriate techniques for that person, looking at what they're used to, their narrative, their experiences, what treatments they like, they don't like, what works for them, what doesn't work for them, why they're there, what's led them to this situation. So it's really important that we individualize the treatment process. And with that individualization, we have to make sure that we discuss communication. We discuss what it is we're doing, why we're doing it, we gain consent, and that manipulation is explained in a modern context, that we are not repositioning structures, we are not changing biomechanics, we're not changing joint position, we are using these techniques to elicit temporary neurophysiological changes. If we don't communicate effectively, we can give our patients unrealistic expectations of what the technique is. And if students don't understand the neurophysiology, understand the whole process, they can have unrealistic expectations as practitioners, which causes problems. We don't want this. Then we moved on to HVLA as the treatment process. And the key emphasis is here is that manipulation is actually a very small part of the treatment process. If manipulation is your treatment process and only your treatment process, then I think you're flawed. If all you do is crack it, then you're missing the whole point. Manipulation is very effective, but it's a small part of the treatment process. Remember, what the patient is doing off the table is more important than what we do on it. These modalities give us temporary neurophysiological changes. They allow us to get the patient into a very fast rehab phase, but if you put everything about your treatment into one modality, this mono-interventionalism, this idea that this one thing is going to fix all, then you are wrong. You're wrong. Treatment is more than a technique. Osteo and physio is more than a technique. It's a philosophy. It's not one modality. And then why this technique? Why are you using this technique on this person? What is the outcome you're trying to achieve? So again, this all goes back to choosing the appropriate technique for the person. You can't just use a sledgehammer on every nail, if that makes sense. It's about choosing the correct technique for the person, adapting the treatment to tailor to the individual. So it's really important that we have a clinical reasoning as to why we're going to do something. We understand what we're looking to achieve with the technique, and we individualize the technique for the patient on the table. And then I think finally, how do you back it up? And social media is great for this. A 30-second clip, crack, and then you see nothing else. You never see that patient again. I've had 16 years of back pain, crack, 30-second video, I feel good, then you never hear from them again. Treatment is about the long-term goal. It's about the exercise. It's about the rehab. It's about the tissue resilience. We take the patient from this treatment table, from this couch, and then it's the exercise phase that gets lasting results. Manipulation is not going to get you lasting results. It's going to help you put the patient into an optimal position to then use exercise rehab where we then get lasting results. So it's really important that we have that narrative, we have that understanding, and we follow through with the treatment. Manipulation is not this crescendo at the end of the treatment, and look how good I am. This is, it's patient-centered, not self-centered. It's about the patient. We've got to have an exercise rehab plan. And this little picture up there is the difference between mobilization and manipulation. And the reality is the only difference between the two techniques is speed, the speed at which you're doing it. I love mobilization. I think it's a fantastic low velocity, low amplitude movement. It's a really effective way of working with the patient, and it fits great with manipulation. So what I was trying to explain there is how, as a therapist, I like to mobilize, manipulate, and then after manipulation, I'm a big fan of mobilizing again, getting that joint imbibition, reinforcing those changes, getting the patient moving in a pain-free way. That I think is a really lovely thing to do, but that's just how I treat. So that's some of the stuff we discussed. It was a big long course. We covered loads of other stuff, but for me, it was all about clinical thought process. What I'm doing, why I'm doing it, what I'm looking to achieve out of it, what's the risk versus what's the reward, how do I incorporate these techniques with a clinical thought process, and making sure that everything I do is individualized to the patient. So a little picture up there to sort of have a little think about.